respected faculties and delegates. Let me thank the entire ISCP team and Proctor Search 2024 for giving me this opportunity. I'll be dealing with minimally invasive procedure for hemorrhoids, or MIPH. So in 1998, Italian surgeon Professor Antonio Longo described the procedure, and now initially as PPH, now it is called MIPH. Reduction in post-operative pain or very less post-operative pain is the advantage of MIPH. We know about the extensional procedure, which already told us Milligan-Morgan, and other fixative procedure like hemorrhoid lateral ligation and Hemorrhoidopexy. The combined effect of both extensional procedure and fixative procedure is utilized in stapler hemorrhoidopexy. I'll be going ahead with the steps of stapler hemorrhoidopexy. The preoperative assessment includes, as already told in any other proctology cases, the examination, routine blood investigations, ultrasonography of abdomen, and a colonoscopy or at least a sigmoidoscopy to rule out any other lesions. An informed consent should be taken as in any other procedure. And the specific bowel preparation is not indicated unless for colonoscopy. Spinal or general anesthesia may be preferred, and the patient should be kept in lithotomy position for the procedure. The first step in the procedure will be an examination under anesthesia. Before that, once the patient is under anesthesia, we should be careful, or the surgery set should be ready. The initial picture shows the things which you usually get inside the hemorrhoidectomy, stapler hemorrhoidectomy set itself, which is a stapler hemorrhoidectomy gun, and the other one showing a thread passer, a circular anal dilator, a half anoscope, an obturator. And the surgical trolley should include preferably a plastic proctoscope, then a metallic one, and the most important one is a long needle holder with a non-toothed thumb forceps. Usually a Prolene suture will be provided along with the set itself, and we need to take another #1 silk suture to fix the circular anoscope. So the procedure will be beginning with examination under anesthesia. This is a preoperative picture. We should examine the patient, any patient under anesthesia, before starting with any procedure. The next will be graded anal dilatation. Initially we will dilate with the fingers, followed by a plastic proctoscope, which is a small diameter. Then a larger one like a metallic proctoscope may be used, followed by the obturator. So graded anal dilatation plays an important role in doing the procedure. The next important step is insertion of the circular anal dilator. We have to fix the anal dilator in such a manner that the white line is clearly seen, and it should be fixed using the help of #1 silk suture. You can see from the image the white line is clearly seen, and you can see the rectal mucosa also. And the next step is the pursing suturing. We use #0 Prolene, which is double needle suture. The half anoscope is introduced, and as you can see from the video that it's always better to hold the needle holder using the fingers rather than inserting the finger in the finger bows, so that you can get a more movement or rotatory movement on your hand. And you can see the white line. Above that you can see the mucosa. We should lift the mucosa and take the bite. Care should be taken. It should be at least 1 centimeter above the levator region. The first bite is taken at the 3 o'clock position. Now take out the anoscope, half anoscope, and reinsert it again. So close to the exit point. Never try to rotate keeping the anoscope inside. Take it out and reinsert again. And again lift the mucosa, take the new bite. The exit point should be taken care so that no loose tissues is there in between. So sequentially the bites are taken in such a manner the entire circumference is covered. Care should be taken at 12 o'clock position. In females, we should be taking care about the vaginal region to avoid, don't take any deep bite to avoid any rectovaginal fistula. Also in males, we should be taking care about the prostate. Now the stapler is placed inside the anal canal. The thread is tied, the needles are cut. So we will hold the thread with the help of a hemostat. Now the stapler gun is taken out. By doing at the anti-clockwise direction at the knob, we can open the stapler, and the safety thing we can remove it. It's always a good thing to look for metallic clips by the help of reflection of light to avoid any mishaps, or the machine mishap we can avoid. We have to gently place the stapler inside the anal canal after putting some jelly on the tip of the anvil and on the sides. Gently place it inside and give gentle traction on the thread, such a manner that we have to make sure the entire pile mass is below the anvil. And we have to tie the proline thread now. We have to usually double like it fairly enough such that the pile mass is snugly fitting into the shaft of the stapler gun. There should not be any loose tissues around the shaft. Fairly good enough, we have to tie the stapler, tie the proline suture. Now using the thread puller, we can take out the thread through the side of the stapler. Then we have to close the stapler by moving the knob in clockwise direction. There will be markings on the stapler. And usually a red line and a green line will be there. The line should cross each other so that the perfect B formation will be there inside the staplers. And now the next step is activating the stapler. We will ask the assistant to hold on the stapler to avoid any untoward jerks. The firing surgeon should be in a comfortable position. And once the stapler is closed or locked, we usually wait for about 1 minute to allow some edema fluid to move away, just like in any other anastomosis using stapler. Then this red safety lock mechanism is removed. Then we have to fire the stapler. It should be in a single firm push. There should not be any jerks happening. You will be able to hear a clear clicking sound, which marks the cutting of the washer inside. Next we will be detaching the stapler. Once the stapler is fired, we usually wait for about 30 seconds. Then we will release the hold, place the safety lock mechanism again to avoid any untoward injury with the blade inside while opening the blades and all. So slowly we will move the knob again in anti-clockwise direction. Slowly we can take it out the stapler. You can see the stapler lines there, clean, and immediately we should look for the completeness of the donut. We can remove the washer and we can see the removed donut in completeness, and it can then and there itself we can see any incompleteness is there or any deficiency is there in the donut. In that places we may be able to put required sutures to avoid any bleeding. And you can see the stapler line clean, there is no bleeding. So hemostasis should be ensured. Any bleeding points should be sutured using 2-0 Vicryl. Once the hemostasis is confirmed, we can place a small anal pack. We are just confirming it again with a proctoscope, and we are putting a small anal pack. This is how we used to do it. We will be keeping a pad, and that finishes the procedure. Patient should be kept NPO for 4 hours and slowly should be started with liquid diet followed by soft diet. They should be allowed to take sitz bath, and lignocaine jelly should be advised before and after passing motion, and betadine ointment may be applied on the outer part. The potential complications may be urinary retention, bleeding, suture dehiscence, rectovaginal fistula, or stenosis and stricture can occur. Thanks to our MIS department team at Kochi. Inviting again all to the upcoming WorldCon. Thank you all. Thank you very much.
If the donut is not, if the donut is not complete, then do you need to take extra stitches there?
Yes, sir, definitely. That is what, just soon after removing the stapler gun from the rectum, anal canal, we should look for the donut. Completeness of donut is the first and most important part, and don't try to rotate it initially, so that we can just point out where the deficiency is. That specific areas we can take a switcher then and there itself to avoid any stapler dehiscence or deficiencies. And to get the proper donut, the technique which we are using is we lift the mucosa and take the bite. So the definitely mucosa, part of the submucosa is also involved while taking the bite. Incomplete. Okay, definitely. Sir.
Yeah, hi. I'm Dr. Binil from Kochi.
Yes.
We have met before. So 3 questions for the entire meeting. One, what do you suggest? You have an entry point at 3 o'clock, which thread? What if I take one more bite and the 9 o'clock position and use a thread?
Yeah.
Have you had any experience doing like that?
We used to do without the counter traction at 9 o'clock position. That also can be tried.
Okay.
That is a good option also. So equal.
You'll get an uniform
trial can be.
Because we had couple of donuts having one side little more, having more tissues and all. Second, regarding the anal packing.
Yes.
Do you feel is it safe? Because already you have a suture, already you have a staple deployed over there, and you forcefully push it inside. Because I'll tell you, there was a senior surgeon who has done it, and it has given away, and we had a very tough time.
Anal pack is not always a necessary.
Yeah.
We used to keep just a small gauze. That's why I saw a small anal pack. We should not forcibly put it inside. We should not distend the staplers and all. Okay. Just a small anal pack to absorb whatever.
Just for a tamponade effect. Third one. All good. So, okay, new generation surgeon comes. He applies a stapler little more down. What will you do? The staple, because it was supposed to be on the dentate line, above the dentate line. What if it comes a little down? Thank you.
You should not apply it like that. That is a. What if the patient comes like that? That's.
What if the staple is deployed? Staple line is down and it is taking the sphincter. Nothing can be done. Only thing is the patient will have severe pain and you will have to go a Mercedes-Benz.
That's all.
Because I had seen the patient like that, and patient was miserable. He can't sit, and he was continuously, abusing the doctor.
To add to this question which has been asked, these patients are bound to have anal stenosis, if that is one. Secondly, if immediately post-operatively patient is having intense pain, in such situation under anesthesia you can take out all the staples, it is quite possible, and give Hylase injection and try to achieve the hemostasis proper and keep the complete wound open, and ask the patient to use immediate post-operative course some anal dilator that can reduce the chances of anal stenosis, and perianal block can be given in the given situation.
Yeah, we gave perianal block.
Yeah.
Madam, one more thing regarding removing the staplers, that is also going to be a very dangerous thing.
No, not at all. It's once those who are very novice to using the MIPH devices, they think that it is very tangential, it is going to give lot of resection area, and it is intense bleeding is going to be there. No, nothing like that. It is in the submucosal plane only, like in resection anastomosis or like any other plane in the submucosal plane of any area. Here only thing is meticulous closure of the submucous area with achieving proper hemostasis is important, and it is quite possible. Do not have a bad idea in mind that once the you staple the you fire the stapler, nothing can be done. No. Second thing is, my question to the speaker is, in what step you will identify that you have misfired the stapler? What are the technical points at which given point you will identify that there is misfiring of the stapler? One thing from my side, that one is, whenever you fire the stapler, there is a clinching sound, like a ice cracking sound if you are in a proper plane. But if you are having lot of resistance to clinch the fist, that is one. Second thing is, with the clinch of the fist, you are not getting the cracking sound. And third thing is, your thread of the proline is getting breaked. And fourth thing is, there is tangential or sequential bleeding circumferentially across the stapler. Lot of bleeding is coming. That is the point in which you should take that the staple has been misfired. And one more point, that there can be misfiring of the stapler along with torrential bleeding. Hastily surgeon tries to pull it out. Hastily surgeon tries to pull the stapler out, but it may not be possible if the misfired stapler is there. In such situation, try to understand the technicality. I am taking lot of time, I think. So
there is a topic, that is panel discussion on complications. If time permits,
but for the fellows, it is very important. They should not go with a message.
These all slides are there in that.
Yeah.
Discussions will happen.
Because I think the fellows who are attending, they should ask lot of questions. Lot of questions. Do not go with any question unanswered. I think we can learn from you. So my sincere take is, you should ask lot of questions. Do not sit quietly. Go with a clear message. Then only this fellowship course is going to have a fulfillment. Even though Dr. Harish is saying that time is less, but I think you should overshoot by asking questions. That is my sincere advice.
Yes, we'll fight, madam. We'll fight.
And
Thank you very much.
we are willing even to extend our, that is even during evening hours, we will extend to finish off the entire talks. No hurry in that, because it is but in Cochin it will be full time based. But in a fellowship course, discussion is more important. So one thing, one answer I will put to that is, just like driving a car, stapler is a machine. The steps you have to follow. Every step you have to follow. Otherwise the donut will not be good. The staple line will be down and you will be in a mess.
So one more comment about this. In female, when we are pulling the thread, we should always insert the finger in the vagina. I have seen 2 cases of rectovaginal fistula. People have fired and there's a hole missing.
In one of the fellowship course in Raipur, when Dr. Hate sir was our president ISCP, performing this stapler hemorrhoidectomy, his stapler misfired. It cut but not stapled. So at that time, the patient has a torrential bleeding. So at that time, what we have done, he passed the proctoscope inside and starts mucosal suturing from one end and completed circumferentially like a chief test technique. And he finished off. So that's what can be done if the staple misfired at below the level of sphincter. At that time, we have to divide the staple at 3 or 4 places, and where the bleeding is there, mucosal suturing can be done.
Many of the surgeons are doing MIPH. It's a very good procedure. My question to those who are doing MIPH. It is a very good procedure. You're taking the sutures, yes, you're putting the anvil inside and then you're cutting. Now, it is 2 centimeter away from the dentate line. It is submucosal. So, you're cutting the mucosa also. So, prolapsing mucosa is cut. One thing, you reduce the prolapse. Now, submucosal de-arterialization is also done. Then why there is a recurrence in patients of MIPH? That is the question.
I shall answer it in the discussion.
Yes. So definitely this part, because we have seen this procedure, very nice procedure, MIPH, very nice. Within 48 hours, patient is away. And this procedure gives less pain. But that procedure will be, why it is there, he will be answering that.